Good afternoon. It's my pleasure to chair this clinical symposium. Our first speaker, Dr. Hussein Raef, who is a consultant endocrinologist in King Faisal Hospital and Research Center in Riyadh, Kingdom of Saudi Arabia. He's going to talk about neuroendocrine tumors. Please, Dr. Hussein.
Okay. Good afternoon, assalamu alaikum. And again, thank you so much for this opportunity to be face to face with you. I realize that a lot of people are watching virtually, maybe much more than physically, but for giving me this opportunity to present this topic. This area is special for me because it's something I got interested in years back, which is neuroendocrine neoplasm or tumors. The new name for it is neuroendocrine neoplasms. And because we saw those cases at King Faisal Hospital in Saudi Arabia, though the cases were scattered, there was no kind of theme to follow those patients. They were in different departments. They were managed in a very different ways, and we realized that it was important for us to manage those patients in a more systemic and standard way. So we developed a small team. We called it then Saudi Neuroendocrine Tumor Task Force or team, which was a multidisciplinary group of different specialty, and we start to really look in this issue and how those patients were treated or diagnosed. And fortunately, over the 10 years later, we were glad that most of the patients were treated according to certain algorithm. They met the standard for treatment, and more so, we had the opportunity to bring almost all type of methods of treatment to the hospital. So we were fortunate really in that regard. But this is a little bit difficult field, and you can appreciate probably that the history of neuroendocrine tumor just started only at the late 19th century, and certainly not till the mid-20th century that the definition of the disease was a little bit clear, or even at the end of the 20th century. It was this gentleman, Oberndorfer, that first described the carcinoid tumor. At that time, he didn't know what exactly it is, but it was to him just a slow-growing cancer, basically, that he observed in the gut, and he was a pathologist. It was later that serotonin was discovered, and later on, the nature of those cells, the neuroendocrine cells, was also found that those are the cells that is able to produce certain hormones, and they have certain characteristic. The description of gastrinoma and ZE syndrome was first in 1955, and the first real classification of gastrointestinal pancreatic tumors by the WHO was in 2000. So this is a very special cell that is arising from the endodermal stem cells. It has the ability to secrete certain protein. It has receptors, and important receptors, the somatostatin receptor, which has a lot of implication in the treatment and the diagnosis of these tumors. And although they are considered to be relatively rare, there is an increase in the incidence and prevalence of those tumors. Certainly over the end of the 20th century, there was a significant increase, few-folds increase in the diagnosis of those tumors. Unfortunately, the diagnosis of NETs or NENs occurs late in the course of the disease. Their symptoms can be very nonspecific, and on average, it takes 9 years to diagnose a patient with neuroendocrine neoplasm. Because of this, this delay in diagnosis can impact the survival of the patient. Therefore, awareness and early diagnosis may be important. Now, the WHO came with a number of classification that depends on grading, and the grading is based on basically the mitosis and the Ki-67% index in a G1, G2, and G3, but also there is staging, which is based on the tumor size and the presence of regional or distant metastases. And therefore, those tumors who has more differentiation, we call them neuroendocrine neoplasm or tumors, and only when they become poorly differentiated that we call them poorly differentiated neuroendocrine carcinoma, and so on, whether they have localized or advanced staging. A more current classification is the 2019 classification, which is slightly different. Here, well-differentiated neuroendocrine tumors are the ones who have Ki-67 less than 3% or mitotic index less than 2. G2 is between 2 and 20 or 3 and 20 for Ki-67. Now, G3 here was actually differentiated into well-differentiated NETs with G3, meaning more than 20% index or mitosis, because they realized that some of those tumors still behaving in a slow and not a very aggressive manner. However, some of them become poorly differentiated, G3. So G3 now is divided between well-differentiated and poorly differentiated. The poorly differentiated G3 tumors are basically very, very aggressive tumors and should be handled by oncologists. And an example, kind of classical example, is the small cell cancer of the lung. Now, this grading is important because it does correlate with survival. So G1 has excellent survival, G2 has less, and G3 has much worse survival than G1 and G2. Now, why is it important to early recognize neuroendocrine tumors? Because lower grading and lower staging tumor have better prognosis. And those tumors are not without consequences, local and systemic morbidity, whether due to excessive secretion of hormones or due to local compression, can cause a lot of issues and problems to the patient. And although these tumors, especially the G1 and G2, can be indolent and can take years to progress, they eventually can kill those patients. So there are challenges, however, for early diagnosis because the disease is rare, so we don't think of it so much. And the symptoms, as we will see, they're very nonspecific. The presentation, therefore, can be late, and many of presentation come with metastases, and there are limitations in the diagnostic tools we have. This is just to show you that liver metastasis at presentation can be seen in almost half of the cases with intestinal neuroendocrine neoplasm. However, they're much less with the appendix, rectum, and stomach. And this is a great opportunity to diagnose those patients using endoscopy. And actually, endoscopy has really changed the look for those tumors, the prognosis for those tumors who are diagnosed by endoscopy is way better than, let's say, intestinal or pancreatic tumor, where metastasis can happen in 50% of the cases. So here we have an opportunity to make an early diagnosis. Liver metastases also correlate with survival. So the more metastases we have, the higher the burden of the liver disease, the liver metastasis, the worse is the prognosis. Now, clinically, of course, if we just limit our discussion to the gastrointestinal neuroendocrine neoplasm, we can say intestinal neoplasm is about 50% of the total. And out of this, only 20% will come with the carcinoid syndrome, the standard carcinoid syndrome, the one with the flushing and diarrhea. So 80% of the time, those intestinal tumor will not have any symptoms other than local symptoms or discovered incidentally. So patient might present with abdominal pain, hemorrhage, or obstruction, or just found to have metastasis by chance. The pancreatic neuroendocrine tumors represent 30% of the total gastrointestinal neuroendocrine neoplasm, and only 10 to 30% of them will be functional. And they present with this classical endocrine syndrome that we kind of find it quite interesting, like insulinoma or gastrinoma or ZE syndrome or glucagonoma, which are relatively rare. However, 70 to 90% of pancreatic neuroendocrine tumor are silent and will not have any endocrine presentation. Just a word for the carcinoid flush. It is usually a dry flush. It does not come with sweating. It comes with the purplish discoloration and telangiectasia. Now, clearly, with this, there's a wide differential diagnosis because the symptoms are nonspecific. So sweating, flushing, diarrhea, intermittent abdominal pain, occasionally GI bleed, and of course, some of the patient might present with cardiac disease due to carcinoid heart disease. You can see that there is a wide range of diseases that comes in the differential diagnosis. Indeed, in this survey that was done in Europe and North America, to patients who have neuroendocrine neoplasm, they were asked many questions regarding their diagnosis and symptoms. And just in relation to the time between the first symptoms and the diagnosis, the average was 52 months. So this is quite a bit of time to diagnose those tumors, even internationally. I'm going to give you a flavor for those presentations in two of patients that we encounter, or I encounter during my practice at King Faisal. This person is 61-year-old. When he presented, he was on warfarin because of cardiac disease that is not related really to carcinoid. And he had hematuria because he had an angiolipoma on his kidney and was bleeding just because he was on warfarin, completely unrelated to the issue of neuroendocrine tumor. But because of this presentation, he gets a CT scan of the abdomen, and that showed a couple of, actually more than a couple of lesions in the liver. And it shows also a mesenteric mass right here. And an FNA done from the liver showed that he has neuroendocrine tumor with a grading 1. And it's like, what are we going to do with this patient? I will give you some follow-up by the end of my presentation on this patient. And of course, we did octreotide scan, which we used at that time. This is quite almost 12 years ago. And it showed the uptake due to the presence of somatostatin receptors in those tumors in the mesenteric and liver. Another patient who I saw her, I think, the first time I came to King Faisal in year 2000. She had a history, actually presented in 1997, with a 1-year history of progressive weight gain, fatigability, acne, amenorrhea, and was diagnosed to have Cushingoid syndrome. Her history that a year before, she had a lung carcinoid tumor, or neuroendocrine tumor, resected completely a year before. Her investigation showed multiple liver lesion metastases, positive on octreotide scan, and the diagnosis of Cushing syndrome was she had florid Cushing syndrome. She had no recurrence of her lung carcinoid since then. She's still my patient till this moment. So we'll come again to that patient at the end. Diagnostic pathways. Chromogranin is one of the things we use when we suspect neuroendocrine tumor. However, it's only high when there's a burden of disease. So if you have a small tumor, probably will come normal. Unless you have large tumor or metastasis, the chromogranin probably will not be very helpful. However, it is very nonspecific, so any neuroendocrine tumor can secrete chromogranin. And this is the beauty of chromogranin as a screening for when you suspect neuroendocrine tumor. However, it has a pitfalls because it is nonspecific for, it's positive in all kinds of neuroendocrine tumors. It's not specific for any type or location. And it can be falsely positive in those who use PPI. So you have to stop the PPI for 4 weeks before you measure the chromogranin. 5-HIA, urine 5-HIA or 5-hydroxyindole acetic acid, it's more specific. However, it's only positive in those who have carcinoid syndrome, which we already said those are only quarter of the patient with intestinal neuroendocrine tumor. However, when it's positive, it helps you making the diagnosis. So we depend a lot on radiological investigation. We use CT, and I highlight it should be triphasic, meaning arterial and venous, to give you the real data. MRI, octreotide scan, which is now replaced by the gallium PET scan, and endoscopic ultrasound. PET scan occasionally, it doesn't have a big role, and also intraoperative ultrasound. So this is just an example of how CT should be triphasic. So this patient on the non-contrast might look normal, but this lesion will not show till you give a contrast. It's clear here, and then the washout, it disappears. Some of the lesion may be the opposite, so it might show actually with the washout rather than the contrast, and it all depends on the characteristic of the tumor. MRI, certainly it is more specific or more sensitive. For PET gallium, as I said, it has replaced the octreotide scan. It is better one. It is more sensitive, though sometimes it gives you more data than what you want to know. So it's like technology here ahead of us may show us a lesion where we think we have complete remission in the patient and get us in trouble. But like in this patient, FDG PET was negative. However, octreotide scan showed clearly not just liver lesions, but lung lesion as well. So PET FDG is only useful in the poorly differentiated neuroendocrine tumors, and it associates with poorer prognosis in those patients. Let's go to the therapeutic options, and here where people differ, and here where you need a multidisciplinary group in every single patient with neuroendocrine tumor to decide the pathway of the treatment. And always I tell the patient, if you ask 3 people, they will give you 3 different pathways of the treatment. And this is related to many options we have. It depends on which one you're more comfortable with, which one is more available to you. But surgery still is the cornerstone of treatment. And you always have to look for curative surgery whenever possible, or ablative surgery, which is more often. Debulking is still very common because we believe debulking of the tumor, liver metastasis and so forth, can improve quality in those who have functional tumor and even improve survival sometimes. So we do debulking surgically. We do it also in liver-targeted treatment like radiofrequency ablation or embolization, TACE, which is transarterial embolization, or chemoembolization, or recently radioembolization of liver metastasis. Medical therapy, the cornerstone of it is really somatostatin analog. Now we use it for functional tumor, but sometimes also we use it for non-functional tumors based on recent studies like the PROMID study. Alpha interferon is only used in certain centers, but now also, especially for pancreatic tumors, mTOR inhibitor, everolimus, as well as sunitinib, a TKI, has been approved. Chemotherapy, like especially with CAPTEM regimen, capecitabine and temozolomide, is especially useful in G2 tumor and especially pancreatic neuroendocrine tumors. And then we have the radiation, whether it's a local radiation or even more important recently, the use of lutetium in what we call PRRT therapy. This is a systemic therapy that has proven not just to decrease, to improve the progression-free survival, but for the first time improving overall survival. We'll go through this quickly, but factors that influence your decision could be the type of tumor. Is it grade 1, 2, or 3? Is there a burden of liver metastasis or not? Is this functioning or non-functioning? Is it positive for somatostatin receptor? What is the growth rate and the patient status, but also what's available to you in your center? And those patients should be treated in special centers, large centers that have this availability. So I'm going to share with you one of the most updated guideline by this group, led by Mariam Pavel, who's a leader in this treatment of neuroendocrine neoplasm. And the role of surgery was highlighted here. There is a little bit of different approach, whether it's pancreatic or neuroendocrine or intestinal. So this is pancreatic neuroendocrine tumor. And always you have to go for resectable. If you have a resectable disease, you have to go to full resection. However, if the pancreatic tumor is small, meaning less than 2 centimeters, then you can watch it. Because neuroendocrine tumors, if you prove it's a neuroendocrine tumor, of course, by scan or by FNA, it's usually slow growing. And especially if you're dealing with a patient with multiple neuroendocrine neoplasia, you might wait for surgery till there is a growth. If there's doubling or quick growth, or if the tumor reached 2 centimeters, or according to some guidelines, 3 centimeters, then the chance of metastasis become higher, and then you have to go to surgery. If it's more than T1, meaning more than 2 centimeters, then certainly surgery should be done whenever possible. However, if you already have metastasis, then you have to ask whether your surgery will be useful or not. And that depends on grading of the patient. So if he's grade 1 and 2, and still the Ki-67 less than 10%, slowly growing tumor, and you can go for resection or debulking of at least 60 to 70% of the primary and metastatic tumor, then you have to go to surgery again. However, if Ki-67 is high, meaning this is a progressive and it's not completely resectable tumor with a lot of liver metastasis, then medical treatment should be applied. There's even a place for liver transplant if the disease is only in the liver and it's not beyond the liver, the metastasis is not beyond the liver, and if the Ki-67 is not extremely high, meaning less than 15%. Now for the neuroendocrine tumor arising from the small intestine, it's almost the same thing, where you do resection whenever possible, when it's a small tumor, even when it's a larger tumor, because here the tumor can cause obstruction as well. And if you have metastasis already, and again, if the overall behavior of the tumor is not completely aggressive, then surgery should be looked at. However, if you are dealing with advanced metastasis and Ki-67 more than 10%, so sometimes we go to medical therapy first. We might reassess the surgery, possibility of surgery later on. And we will talk about the medical therapy in a minute. So medical therapy, there is a special treatment for those patients who have carcinoid syndrome, which are 20% of the total patients. Because of the functionality of the tumor, then you have to be a little more aggressive in treating those patients because of the morbidity of the secretion, whether it's a carcinoid or something else. And in those patients, if they are positive for scan, for octreotide scan, meaning have receptor for somatostatin, then the most effective therapy is somatostatin analog, octreotide, or lanreotide. And if that works, that's maybe all what you need to do if the patient already have non-resectable disease. But many times we have to debulk the disease. Of course, when we have carcinoid syndrome, almost always we have liver metastasis. So debulking of the liver metastasis to decrease the bulk of the disease, or even going to local-regional therapy like embolization, radioembolization, or chemoembolization, will decrease the burden of disease and might improve survival. If you're successful, it's okay, but if not, you might go beyond the octreotide or lanreotide therapy to higher doses. You might try interferon, or you might go to systemic therapy with PRRT using lutetium, or using, as we mentioned before, chemoembolization or liver-targeted therapy. Now, what is the medical therapy available for patients with neuroendocrine tumor? We do have a number of therapies, and this can be also divided, depends on whether it is intestinal or pancreatic. So if we start with the intestinal one this time, it all depends on the grading. So if you have a low grade, low Ki-67, less than 10%, very slow growth, then the treatment is somatostatin analog again. If that fails, you go to local-regional therapy targeting the liver metastasis, or lutetium-based therapy, PRRT. Now, when it's higher grade, or when the somatostatin receptor are negative, which is 10% of the cases, or 15% of the cases, then you can go to these other options. Everolimus, which is an mTOR inhibitor, lutetium, again, PRRT therapy, or local-regional therapy, and even chemotherapy. For pancreatic neuroendocrine tumors, they seem to respond better to chemotherapy, especially the combination of CAPTEM, capecitabine, temozolomide, or even streptozocin 5-FU. So those are the one we used as a second-line therapy for G2. However, for G1, we still use somatostatin analog, and if that's not enough, patient progress, then we go to the chemotherapy or PRRT as last resort. Now, just quickly, the role of somatostatin analog like octreotide or lanreotide is very essential then in a functional tumor, and also even non-functional tumors that are G1, slowly progressive, because those agents turn to be not just suppressing the function of the tumor, but suppressing the progression of the tumor. This was proven in the PROMED study, which compared the progression-free survival in those who used octreotide versus those who didn't. And it didn't differ whether it's functioning or non-functioning tumors. In both sides, octreotide was able to slow down the progression of the disease. And this is also true in another study called Clarinet using lanreotide. Now, this study looked in everolimus, which is mTOR inhibitor in pancreatic neuroendocrine tumor, and also showed improvement of progression survival. There was another study called RADIANT-4 that looked in the intestinal. So everolimus, mTOR inhibitor, is indicated in both. This is probably more exciting, which is the use of lutetium, the PRRT therapy, which is basically radioactive material, lutetium, that is combined to octreotide-based protein and adhere to the somatostatin receptor, causing radiation to the tumor directly. So it's a systemic therapy. Actually, this study was the first study, prospective study, that showed that this type of treatment works. And not only improvement in progression-free survival by almost 80% improvement, but also showed improvement in overall survival. And this is the only agent, actually, out of the agent I mentioned, that improved overall survival. Yet, we still keep this type of therapy to metastatic disease as last resort most of the time. Now, I'm going to go back to those two cases quickly just to show you the type of treatment they received. You remember this patient? Oh. Can you give me a few slides? We're almost done. So this patient who presented incidentally, and this is his treatment over the time. He received first just octreotide because they thought he's not operable because of his high risk, not because of anything else. He progressed. He received I-131-based therapy, which we don't use anymore. We use now lutetium. Then we used everolimus and sunitinib. And every time he would progress and then stabilize, progress, stabilize. Finally, because he had cholecystitis, we were able to resect actually his primary tumor and the lymphadenopathy just by the way of his cholecystectomy. And he's still following with me with stable disease. Now, like 14 years later. This patient is very interesting, the one presented with liver metastasis and from a lung primary tumor and Cushing. And this, what we did there is kind of unusual. We give her chemoembolization of the liver to control her Cushing disease. She went 9 years in remission of her Cushing, 9 years, even that she has the tumor in the liver. Of course, she used octreotide all along. And then she had a recurrence, so we went to radioembolization. This didn't work so much, and she had florid Cushing again, so we went and resected her metastasis. They resected a big chunk of metastasis here, and that gave her remission for about 1 year. However, her disease went from G1 to G2, so she became more aggressive. This is her lutetium scan because she received 3 or 4 doses of lutetium, which is our protocol. That stabilized her for a while, continues to progress, and now she's receiving temozolomide, capecitabine. And she's with us now for bilateral adrenalectomy. Yeah. So this is my last slide. The more you do, the better survival it happens. You know, this is 5-year survival. If you do nothing, the survival is so low. And chemo, everolimus, surgery, etc. When you try to resect completely, you get the best survival. And so it depends on how aggressive, yet this aggressiveness has to be calculated upon the risk. This type of course, a center that has all these multidiscipline is needed to manage those patients, which can be quite complex. Thank you so much.